MISC, which is the multi-system inflammatory syndrome in children, because they have adult and children. So presentation, diagnosis, and management. So I have no conflict of interest. The COVID has claimed so far, as of yesterday, this is the WHO dashboard, that's the up-to-date result, of 613 million, or nearly 614 million cases of COVID, all adult and children, of which 6.5 million deaths. Very, very high, okay? Although we so far had 12.5 billion doses of vaccines. And this big slide shows that Europe claimed most of the cases, second, then to the Americas, North and South, then the Eastern countries, Mediterranean, and Southeast Asia. So Southeast Asia before the Eastern Mediterranean, and then the Western Pacific, that's New Zealand and Australia, and then Africa, etc. So children are small number, those who needed the intensive care among those who are affected. And since the beginning, there was a flat initially, then children start to be affected. And this violin shows the children affected in different ages, 0 to 18. But those who needed intensive care, only those who are very small, and I will come to this why, and then less, and then from the age of 9 to 10 and to 15, there are the cases of PIMS required there. Some of them with the comorbidities, congenital heart disease, etc. Okay, and the impact of COVID, as we said, is generally mild on children, except for the small number of children with the multi-system inflammatory syndrome. And first recognized in UK and defined by the Royal College of Pediatric and Child Health before anyone defined it, whether in America or WHO. So started with 3 first children presented with shock, okay, in London. Then they went to Evelyn, retrieved by cats. This is not cats as in animals. That's the system which retrieved the sick children, or STARS also, okay, South Thames Pediatric Respiratory Group. Anyway, so and then retrieval, and then identified, they suspected, and then they developed the criteria for it. Are my slides clear, by the way? Are they clear? Okay. Okay. So just because I see that they are going outside the boundaries of the thing, but anyway, and what is the observation was that the children who get the PIMS or MISC only a month later after the development of COVID. So a month later, the PIMS comes. So it's a latent effect, almost like a reaction, super inflammatory reaction. And this was also confirmed in United States, in various Northwest, West Midlands, East Midlands, London, Yorkshire, in UK, and United States. They showed that that's the rising in COVID, and that's the rising in the latent period, a month after that, and rising also in PIMS cases. Then the Royal College defined it. They came with the first definition, and they put, I'll come to this in more clear thing. It's first recognized in April 2020, initially UK, then Europe and worldwide. It's severe illness with varied presentation, either such like Kawasaki disease or incomplete Kawasaki, that's classical Kawasaki, or incomplete Kawasaki. I'll come to these in more details. Or the toxic shock type, or inflammatory, okay? With or without cardiac involvement. And they usually have fever, sine qua non, all of them, sore throat, headaches, abdominal pain, not all, vomiting, rash, conjunctivitis, shock. That's when they belong to this category. And the COVID-19 maybe or maybe not, whether the PCR or the throat swab thing, okay? Of course, exclusion of other microbial agents like staphylococcal infections, streptococcal, because you can have sepsis as a result of bacterial infection while you are during the COVID era or pandemic. So you shouldn't be confused with this, because the management is slightly it's different, not just slightly, although they both receive antibiotics, okay, as a precautionary measures for the PIMS. So SARS-CoV PCR result may be positive or negative, although 87% in IgG later. The WHO criteria, what does it say? 0 to 19 years. That's the WHO children definition because of the safeguarding thing, okay? With fever has to be, or fever more than 3 days, and 2 of the following: rash or bilateral non-purulent conjunctivitis or mucocutaneous changes like Kawasaki, hypotension, features of myocardial dysfunction like pericarditis, valvulitis, coronary abnormalities, evidence of coagulopathy with raised D-dimers, PT, fibrinogen, APTT, or acute gastrointestinal symptoms. And I will come to the classical cases presented with, and elevated markers, ESR, CRP, C-reactive protein, procalcitonin, BMP, okay, and exclusion of microbial things like the Royal College, but they demand, the WHO, evidence of COVID infection. They say they have to have either evidence now or IgG or raise, i.e. a recent infection. The same with the United States, but the United States children definition up to 21 years. The American remain children up to the age of 21 years, by the way, presenting with fever, laboratory evidence of inflammation, and evidence of clinically severe illness requiring hospitalization, with multi-system, more than 2 organ involvement: cardiac, kidney, respiratory, gastroenterology, gastrointestinal, dermatological, neurological, as I will come to this, and hematologic. They must have fever more than at least 24 hours. That's less than what demanded by WHO. And the laboratory finding the same. Okay, these are the first 58 children reported by Elizabeth Whitaker in the Journal of American Medical Association. These are from UK, okay, and 58, and they found that mainly they are the average, you see, older than the usual Kawasaki, 9 years, 57% males, and only 6 out of the 57 have the comorbidities. The majority are healthy. And they found that many of them, more than one, nearly 40% Black African and 31% Asian, whereas the normal ratio of African and Asian in London, much, much lower, and in England and Wales, much, much lower, but very higher among the PIMS and MISC. They found that 100% they have fever, 50%, half they have shock, half they have gastrointestinal symptoms, diarrhea, abdominal pain, and vomiting. Rash in half, vomiting was 45%, like, nearly half. Conjunctival injection, like non-purulent, 45%. Headaches, 1/3. Respiratory, funny enough, it is a respiratory virus, but only 1/5 have respiratory symptoms. Mucous membrane more, lymphadenopathy only 1 in 6, and swollen hands 1 in 6, sore throat, etc. And they present with those who are in the hospital they need hospitalization, shock requiring inotropes, nearly half. Coronary artery involvement, 1 in 6. Requirement for ECMO, 5%. Okay, that's 1 in 20. Intubation, nearly half. Okay, and ventilation, and acute kidney function, 1/5 of them. And we found that in the PCR, only in UK, 1/5 have, but one quarter, but 87% have IgG. So the majority, they have evidence of COVID. And this is the distribution per ages. You see, the smaller the age group, they clinically Kawasaki-like they present, with rash, conjunctivitis, adenopathy, the mucocutaneous changes, and coronary artery, this majority. Whereas respiratory symptoms are less, okay? An oxygen requirement, cough, etc. Okay? So these are the results of the investigations. When you face a case like this, CRP very high with ESR, neutrophilia, but lymphopenia with low albumin, which is a sign of bad. Even in incomplete Kawasaki, low albumin is bad. It's called atypical or incomplete. Fibrinogen high, troponin high, microbiology negative usually. We say exclude viral infections, okay? And in the clinical features, when they, but the case definitions, less than 18 years, they with fever, persistent fevers or multi-organ dysfunction, shock, cardiac, respiratory, and renal. Inflammation, these are the investigations. We say they are high, CRP, D-dimer, troponin, BMP, okay, and evidence of COVID and exclusion of other things. And that's by age group. They are low, the PIMS in lower age group, but the peak 9 to 10 years, and then they start going down. And then more, that's the American Hispanic, so non-white, then black, and then Asian, and then the white here, Asian and Hispanic, and 56% boys, males. And when it comes to the Kawasaki-like presentation, most of them 0 to 5 years, there with the mucocutaneous changes, lymphadenopathy, conjunctivitis. Whereas in the, sorry, I beg pardon, in the middle, they have 6 to 12 years, they have the less mucocutaneous changes, more gastrointestinal, and more myocarditis. And the older you are, the more myocarditis, and the more gastrointestinal, and the shock. Okay, and that's the shock type. That's the incomplete Kawasaki type. Sorry. And that's the cardiac manifestations with the coronary valvulitis, okay, vasculitis, I beg pardon, whether brightness or aneurysm or dilatation, myocardial dysfunction, poor contraction on the echocardiogram, valvulitis, like mitral valve, regurgitation or aortic valve, and effusion, pericardial effusion there, and arrhythmia. And that's the presentation on the, persistent either fever with elevated inflammatory markers. Only 1/5 of them present with shock and left ventricular dysfunction and arrhythmia. That's heart block and as flutter, okay? And fully made criteria for Kawasaki, 1/5. And they are usually smaller age group. So by presentation, the shock, how do you know it's shocked? You follow the Goldstein et al., the pediatric. That's the definition. What's the definition of shock? Blood pressure less than 5th percentile, less than 2 standard deviation, or need for vasoactive drugs like dopamine and adrenaline and metabolic acidosis with high lactate, etc. Well, presentation for Kawasaki disease, and I'll go through the Kawasaki disease. Typical presentation: 6 months old, previously healthy, 5 days fever, for example, more than 5 days, high temperature, conjunctivitis, skin rash, strawberry tongue, like 4 out of 5 usually, lymph gland, and normal systolic function, echo or dilated coronary artery, high platelets, not low like the other one, high platelets and white cell count, troponin can be normal, sterile pyuria. This is described by Kawasaki disease. I have Tomosoka Kawasaki, who died on 5th of June 2 years ago. I'm still alive, I'm afraid. Okay. And he said it's an acute self-limiting inflammatory disorder, most common acquired heart disease in developed countries, and second most common vasculitis after henoch-Schönlein purpura. And I will come, you have fever sine qua non, have to have fever, and bilateral conjunctivitis, 90% of cases, which is non-purulent, and 70 to 90% polymorph xanthum, but it's not petechial or vesicular, just mucocutaneous. Okay, and then mucocutaneous in 90%, lips cracking and strawberry tongue, etc., and changes in extremities with reddening of palms and soles, and then in duration, and then peeling after 10 days or so when it's late, and lymphadenopathy, usually unilateral, more than 15 millimeter, 1.5 centimeter. Not the common reactive less than 1 centimeter, common reactive and usually bilateral. This is usually, but it's the least dependent one of the criteria. And that's usually acute, subacute, and convalescent stage. The acute usually 1 up to 10 days when they start peeling and things, and the subacute when the coronary aneurysms, etc., everything, and the fever starts settling, and the peeling, the sequamation, etc., and the convalescence. And there's the incomplete Kawasaki described by Kaboshi, Professor Kaboshi, and this can be the incomplete, which are 2 criteria, fever plus 2 out of the 5, not 4 out of the 5 like in Kawasaki, 4 out of the 5 criteria of the one I said. And we follow AHA guidelines. What's the difference in the blood test between the three groups? You have the PIMS group, the PIMS with TS, they are older children than Kawasaki, higher white cell, higher neutrophil, but lower lymphocyte, lower hemoglobin, lower platelets, whereas in Kawasaki higher. And higher CRP, well, similar in liver function, except for the atypical, and lower albumin, okay? Higher ferritin, higher troponin, and similar D-dimer in both, okay? Microbiology, these are the investigation. We do blood culture, we do full blood count, all of these, based on what I told you, okay? And we do vitamin D level, because one of the useful adjuvant in treatment is vitamin D, I'm afraid we found it. We do lumbar puncture if they are septic, ECG, of course, and EEG if they have neurological symptoms, and imaging, echo and chest X-ray. Now, the presentation of the patients, of 183 cases that's presented there, shows that black race, higher inflammation, and imaging abnormalities. They have a lot of them, obesity, non-Caucasian, black or Asian, okay, males tendency, and evidence, of course, of COVID, okay, in 62%. All presented with fever. Gastrointestinal symptoms very high with the neurological finding. Those who present with shock, how do you manage them? The management by presentation, resuscitate, and we give still antibiotic and things, and methylprednisolone or low dose aspirin. We give them low dose because of bleeding tendencies. Okay, and we give IVIG in the vast majority. IVIG, biologic factors if they have respiratory distress. Okay, and remdesivir early. Okay, antiviral. If they have KD-like, Kawasaki-like, okay, which is the usual age I told you about, and if they have low albumin, shock aneurysm, or failed IVIG, but normally we follow the guidelines of Kawasaki, which is IVIG 2 grams per kg with aspirin initially high dose, and then we lower it when the inflammatory markers are low, okay? And of course, repeat the IVIG 48 hours later if there is no response, and then methylprednisolone. But the atypical, they need methylprednisolone and other things. The group of inflammation undefined, they are neither in shock nor in Kawasaki. You give low dose aspirin and heparin with IVIG, but there's a steroid. That's the recovery trial. That's a study called the recovery trial. Okay. In the shock, they have the standard protocol, melatonin, that's in the intensive care. The KD, IVIG, aspirin, steroid. The cardiac dysfunction, we give IVIG. We have to be careful with the volume. We don't want them to fill them. They are in shock. Steroids and treat arrhythmias. Okay. And these are the antibiotics. We give antibiotic, antiviral, immune modifying like IVIG and steroids. Adjuvant, which is the anakinra, which is the interleukin-1 antagonist, and interleukin-6, tocilizumab. Okay, that's only in severe cases, especially with respiratory distress, and they need intensive care, intubation, etc. And antithrombolytic, like low molecular weight heparin. This is a long list. Again, summarize what I said, but I'm not going to go through it. Okay, these are the doses of it, and guidance to you. And these are how many of those who've been admitted had immunoglobulin 71%, corticosteroid nearly also 2/3. Okay, anakinra only 5%. Those who need ECMO and intubation and respiratory distress. Infliximab as anti-TNF, and 1 in 6 we give. Okay, that's the bio. Supportive 1/5. Okay, follow up. We do for those who present with, let me just take this up. Actually, okay. Non-cardiac involvement. We must do echo, ECG, and Holter, okay, and give them aspirin. But 4 to 6 weeks, we do the echo again. And if all well, we stop the aspirin, okay? And if coronary is okay. Sorry, go back. But if there is any abnormalities, we can carry on, okay? Those who have myocardial dysfunction and elevated troponin, they need aspirin, MRI, echo, ECG, and we repeat the ECG and the echo, and we follow up to 6 months. Usually resolution happens then, okay, in majority, okay? And that's how we do them. The role of the echo is to guide us for early anticoagulation if they have, aneurysm, if they have myocardial dysfunction, if they have thrombus, okay? 2 weeks, we look for any development of coronary artery. That's why we do 2 weeks, and then 6 weeks, define whether there's any persisting abnormalities of the coronaries, okay? And there's extra cardiac manifestation. Typical case of PIMS or MISC, a 13-year-old boy presented with fever, temperature 39 degrees, tachycardia, severe lower abdominal pain, vomiting, mild cough. Differential diagnosis, what? Appendicitis. They take him to because he's got high white cell, CRP, etc., normal urine. They take him to theater, normal appendix, but he progresses into shock, deteriorate. Then he has high CRP, calcitonin, BMP, D-dimer, ferritin, and then, oh my God, this must be PIMS. So that's how they present sometimes. And then shock, okay, they went to intensive care. So GI symptoms, majority of them, they have it. GI symptoms and inflammation of the ileum and colon, okay? And this is the GI distribution: abdominal pain 40%, vomiting 30% in PIMS, all PIMS and MIC, diarrhea 1/3, nausea, fever, 50, those who present with things, okay? And that's 50 of the 50 cases, by the way, of the 50 cases, that's 100%. No GI symptoms, only few. Gastrointestinal manifestation, these are the summary of some lots of studies, okay? You can have children with liver dysfunction, KD-like, in Kawasaki, you can have hypoalbuminemia, elevated liver function, and you can have high drops of the gallbladder, yes? High drops of the gallbladder may require, even in very few, cholecystectomy. Majority resolved. In neurological problems, high. In COVID-19 and PIMS, the status epilepticus presented, 27 cases of COVID-19, 27 and 52%, okay? They have status epilepticus 7, encephalitis 5, Guillain-Barré, that's Stock and Graven-Stock fashion, neuropathy, okay? In 3, acute 5 in demyelination, ADEM, okay? 3, Korea 2, isolated encephalopathy 2, and transient ischemic attack, TIE, like syncope, but TIE, whereas higher in PIMS, higher in 25 cases, 48% here, BAME, okay, the majority. And then you have encephalopathy, 88%, peripheral nervous system, involvement, 40%, behavioral, 36%, hallucination, 24%, admission to ICU high. And even the MRI, you see demyelination changes, okay? Long-term complication, you can have, the vast majority, they get better by 6 months. The vast majority, no sequelae. And that's what shows, these are the wheels, shows initial, all these systemic, gastrointestinal, coagulopathy, renal, okay, dermatological, respiratory, okay, neurological, the green, okay, and the ENT. All these, by the age of 6 weeks, much better. Look how old, very high initially, and then by 6 months, very, very low, but they have the long COVID with POTS, postural orthostatic tachycardia syndrome. What we see is just tip of iceberg. We are still learning, even though 2.5 years into the pandemic. So in summary, they have 3 clinical presentations. I felt either shock or Kawasaki disease-like, or fever and hyperinflammation. Multidisciplinary approach, not one single person work. Acute management depend on the phenotype, whether you need PICU or general, and follow-up depending on the presence of myocardial injury, ventricular function, or coronary involvement. PIMS, of course, is an infrequent and heterogeneous disease. It can mimic some pediatric inflammatory syndrome, like KD or macrophage activation syndrome. Myocarditis, it's 1/3 of the cases. Clinical characteristic, very distinctive with pediatric COVID-19 infections. Gastrointestinal symptoms very common, abnormal liver function frequent, hepatitis and hydrops expected, and neurological symptoms association are common. Okay, and PIMS is an infrequent, well, we said that actually. And key points, we are still learning, talk to, liaise with the cardiologist, nephrologist, or respirator, and basically intensive care. Okay, we have these, the British Pediatric Supporter Group and recovery and the Diamond studies, all going, these studies still going, okay? And thanks to all those who are involved. Thank you very much for listening. These are more references.
Majeed, thank you very much indeed. Thank you very much for your illustrative presentation. Actually, weekly at Majeed, I can see messy, but I would like to ask a question. How do you think this is most probably messy at the beginning?
At the beginning, yes.
Yes, at the beginning, when the child comes.
Yeah, you see, the mess, it doesn't have to be shock, as I said. It can be undefined inflammatory things with